Good evening po. Sir, pwede na po mag-start.
Go ahead, Ate.
Okay, so i-slideshow ko lang po. Kita po yung slide.
Yes
Kita
po.
naman.
Okay, so good evening. For this lecture, we will tackle on the critical appraisal of articles on diagnostic test. No? So before we begin, so some little introduction lang. So first of all, before tayo pumunta sa appraisal ng diagnostic test, we have to be aware of why we order the laboratory examination. So ano ba yung dahilan usually, no? Why we order labs? So for the first year na lang, si Nathaniel.
Ay, hello po, Doc. Good evening po.
Good evening.
We order po a laboratory test po to guide us po in the management po of our patients po.
Paano guide?
Ano po, Doc? For example po, doon po sa pag nagpa-CBC po tayo, halimbawa po, tas elevated po yung WBC count, maybe we can pinpoint po yung etiology ng illness po ng pasyente, maybe we can order po the appropriate antibiotic therapy po, depende po dun sa natin. Kino-consider po natin.
Okay, so what you're saying is you order laboratory examination to diagnose a particular disease, tama ba?
Support po.
Hello, sorry. Ako ba lang? Choppy yata siya. O ako na yung choppy. Hello? Hello? Sige, hello?
Ay, Doc, pang support po doon po sa sa assessment po with the patient po.
Oo nga, to help you diagnose.
Yes, pang support.
Ay, hindi. Ibig sabihin pang support. Yeah. So it will help you establish the diagnosis, tama?
Opo.
Okay, so where's to diagnose or to help you establish? Hindi ko naman sinasabi na yung lab yung magda-diagnose talaga, pero it will help you establish the diagnosis or to diagnose a particular disease, tama? So ano pa, Cecilia? Why do we order laboratory examinations?
Doc, aside po from establishing po the diagnosis, we need to rule out po other diseases.
Okay, sige. Ano pa kaya? Si Kyla. Kyla? Judy ba? Ay, sorry ha.
Doc,
Sige. Si Shannon.
Doc, to help us prognosticate po.
Okay,
Yung
very good.
Opo.
So prognosticate, no, patients, no? So ano pa? Nathaniel? Or yung mga, tingnan natin yung ibang seniors. Si Alfred.
Confirm the diagnosis, Doc.
Okay, to establish diagnosis, ano pa? Sabi nila to establish, to prognosticate. Ano pa? Maki.
Nasabi na po lahat.
Sige, Gemma. Bakit ka mag-order ng labs? Usually.
Wala na akong masabi.
Sige, si Doc Bao.
Doktora, for monitoring.
Very good. So monitor, 'di ba? Mga HbA1c, ganyan, di ba? To monitor. So actually, no, these are some of the reasons we order laboratory examination. So first, no, syempre, to diagnose the presence or absence of a particular condition. So sabi nga nila, no, to rule in or rule out, no, a particular disease. Number 2, to plan an intervention. So minsan, di ba, yung mga surgeon natin, nagpapa-CT scan yan, ganyan, para alam nila extent ng tumor, ganyan. So magpa-plan sila, di ba, ng surgery nila. So they order that laboratory examination or imaging, no? And then, another reason is to monitor response to therapy. So, yan. So, ibig sabihin, example is HbA1c, ganyan. So, kung bumababa ba, tumatalab ba, no? Or yung mga viral counts, no? Sa mga HIV patients, no? Kung tumatalab pa yung ating, sa kanila, yung mga gamot. And then we also order laboratory examinations to estimate risk of future events and to determine prognosis in patients with a known disease. So parang magkadikit lang naman kasi itong dalawa na to. Like for breast cancer, di ba, may mga ino-order tayo ng mga markers, no, para makita natin yung prognosis nung pasyente. Okay? So yun nga. So ang point dito is we have to order laboratory dahil may kailangan natin sila. We just don't order laboratory just for the sake na kasi dekahon ito talaga yung usually na ino-order. So, ayan. So, ano yung problema dito sa cartoon na to? Sige, si Nathaniel. Nathaniel? Sorry, choppy. Ako lang ba yun?
Hello po. Doc. Po ulit, Dr.
Sorry. Hello? Medyo choppy.
Ay, yes po, Doc. Sorry po. Ano po ulit po?
What is wrong with this picture? Or ano yung pinapakita sa'yo ng picture na to? Ng image na to?
Ano po, Doc? Visible pa. Buhay pa po yung pasyente dito, Doc.
Hindi, this is a joke, no? Well, obviously, sorry. So obviously kasi, no, yung point ng image na to is that, yun na nga, no, nakaharap na sa'yo, buto na lang siya. And then, mag-order ka pa ng x-ray just to be sure, diba? So, tama ba yun?
Hindi.
So, ang point is, ayun nga, kung hindi magagamit pa, kung yung, if you will order a laboratory na hindi naman mag-change yung management, no, or wala na siyang added value, don't order it. So, iwasan natin yung mga decahon labs or yung mga excessive labs for our patients, especially those na yun nga medyo financially constrained, no? So, let's have an example. So, Cecilia, pakibasa nga.
General data, 20-year-old female with a chief complaint of hypogastric pain, history of present illness po on the day of consult with crampy hypogastric pain coinciding to the first day of menstrual period. No fever, no dysuria, no frequency, and no abnormal vaginal discharge. Past medical history, no known comorbidities, OB-GYN, G0, P0, denies sexual contact yet. LMP is 30 days ago. Menstrual period, regular monthly interval, consuming 2 to 3 pads per day, lasting for 4 to 5 days, with dysmenorrhea on the first and second days. No gynecologic surgery.
Okay. Sige. So, ang pertinent PE is unremarkable except for the tenderness on the hypogastric area. So, if you were the patient, Kyla, what will you order for this? If you were the physician, what will you order for this patient? Ay, sorry, wala. Nasa duty pala siya. Shannon.
Hello, Doc.
Mm-hmm.
Pwede po ng CBC tsaka urinalysis, Doc. Pero kung based po sa history kasi niya, parang magko-consider na lang din po tayo ng dysmenorrhea actually.
So, what will you order?
Wala.
Wala.
Wala. Okay. Si Nathaniel.
Ay, hello po, Doc.
Mhm.
Ano po, Doc? Possible po urinalysis po, Doc, with PT pa rin po, Doc.
Urinalysis with PT. Si Cecilia.
Same po, Doc. UA with PT.
Okay. Why? Si Shannon, why? Ang sabi ni Shannon, wala raw siyang i-order. Tama, Shannon? Shannon?
Yes, Doc.
Oo, kasi raw, based on the history, mukhang dysmenorrhea talaga. So, for Nathaniel and Cecilia, why UA with PT?
Doc,
What are you looking for sa UA?
sa UA po of possible UTI.
Will you treat WBC na greater than 5 sa isang female of reproductive age na walang comorbidities and no abnormal vaginal discharge and walang symptom?
No po, Doc.
Okay.
Just to be sure lang po, para isabay na din po yung pregnancy test.
What do you mean? Ito kasi yung point nga. So if you see, sige, ang sabi mo kasi is you want to do the urinalysis because you want to see if may bacteria ba or may pus, may
UTI
WBC
daw.
or
Yes,
UTI. Pero paano mo ba i-diagnose ang UTI?
Doc, if symptomatic po with dysuria and fever, we're considering acute pyelonephritis. Kaso nga lang po asymptomatic ang patient. Usually po isasabay na lang a urinalysis just to make sure and then with a pregnancy test. Kasi nga po, the patient is 20 years old, reproductive age pa din po.
I think wala akong question sa pregnancy test, although sinabi nga niya ang LMP niya is like a month ago
30
and
days
first
ago.
day na.
Yes po.
Oo. And ngayon ay nagko-complain siya ng hypogastric pain. Hindi ba sinabi dun sa history na first day ng mens niya? Coinciding with the first, ayan. So anyways, sige, so wala akong question with the preg test if you want to do it. Although, yun nga, coinciding siya with the first day of menses niya. Pero why do urinalysis? Hindi kasi, ayun nga, yung point ko is, hindi dahilan yung, para isabay na lang po yung PT. Because we could always order PT lang and not urinalysis. Tama?
Yes, Doc. Pwede pa.
So, yeah. Si Nathaniel, baka meron siyang ibang dahilan for the urinalysis. Nathaniel?
Naman pong dysuria.
Wala siyang dysuria frequency. Wala siyang abnormal vaginal discharge. Except na nagme-mens siya. Yeah. May maisip pa tayo? Ayun. So, I'm just pointing out in this exercise na, we have to see yung history and PE muna ng patient and then subsequently order labs from our main differentials and not just order labs kasi yun na usually yung ginagawa or ayun. Tapos yung urinalysis naman kasi kahit na lumabas yan, asymptomatic bacteria in a reproductive age na female na walang comorbidities, na hindi pregnant, no, ay hindi naman iti-treat. 'Di ba? Tama pa, guys?
Yes po, Doc.
Yes,
Okay.
Doc.
So, yun lang. So, for me, actually, pwede siguro yung PT, no? Although, yun nga, just to be sure na hindi siya pregnant, although sinabi kasi niya nagme-mens siya, so baka pwede kang hindi ko siya i-PT at that time and just treat the patient for dysmenorrhea. However, no, kunwari, no, usually sa ibang institutions, they will do this CBC-UA pregnancy test because tekahon siya, no, na usually ano yun, in-order for these kinds of complaints. So then, ang lab results na lumabas, halimbawa is, the all labs were normal except for the UA, which revealed, epithelial cell na few with WBC na 6 to 7 and RBC of 10 to 20. And the diagnosis that the physician made was dysmenorrhea UTI. So, ang ginawa niya, syempre, dahil ang diagnosis niya is dysmenorrhea and UTI, the patient was given afloxacin and mefenamic acid PRN. So what's wrong with this? Shannon.
Yung drug of choice daw.
Okay, so pero sa drug of choice.
Sorry, di ko sure.
Okay, so ang nangyari kasi, the physician treated the laboratory result rather than the patient herself, 'di ba? Kasi nga yun nga, hindi siya dapat tinitreat kung itong ganito yung picture ng patient, 'di ba? It's asymptomatic bacteriuria. So, tests are often requested yun nga, routinely or excessively leading to higher cost for the patients, no? And doctors treating the laboratory results rather than the patient. So, sana hindi natin gawin siya. And doctors should be requesting for the diagnostic test because it will give valuable information and may change the way patient will be treated. Medyo unfair din naman na hindi naman natin pala masyadong kailangan yung lab, pinagastos pa natin or pinundergo pa natin yung laboratory test sa pasyente. Magtatagal pa siya, hindi naman natin pala kailangan yung laboratory exam. Okay, so we go back to this reasons on why we order laboratory examinations or actually diagnostic or mga imaging, no? So for this, for tonight, we will focus on this reason to diagnose the presence or absence of a particular condition. So ito kasi yung point nung sa appraisal to diagnose a particular condition. Pero if you see na yung laboratory examination of ano yun? na ina-appraise nyo ay hindi maganda for diagnosing, hindi naman ibig sabihin na wag nyo na siyang i-order kasi baka pwedeng helpful siya for another reason like to plan an intervention, motor response, mga ganun. Okay, so hindi naman ibig sabihin wag nang i-order. Kung may ibang dahilan, like this for sa baba, pwede nyo pa rin i-order. Pero kung wala namang ibang dahilan na i-order siya, no, wag na siyang i-order kung pangit siya dun sa critical appraisal natin later on. Okay, kasi kung ito lang yung dahilan ng pag-order nyo to diagnosis, nakita nyo na hindi siya maganda, o di order another laboratory examination that will really help in the diagnosis of a particular condition for the patient. No? Okay, so far, malinaw ba? Actually, nasa introduction pa lang tayo. Sige. So before we proceed to the critical appraisal, actually, you need to be familiar with the decision analysis line. So, sino na yung nakarinig ng decision analysis line? Ganito siya. Sino na nakakita nito? Sa mga first years. Familiar ba? Or hindi?
Hindi po.
Okay, sige. So, anyways, we will discuss this. So, essentially, yung decision analysis line is a line from 0 to 100% na disease probability. So, yung parts niya, no, is the diagnostic threshold, the therapeutic threshold. Testing range is the one in between the diagnostic threshold and the therapeutic threshold. And then we have, syempre, dapat pre-test probability and post-test probability. So, we will discuss this one by one. We will go first to the pre-test probability. So what is pre-test probability? It is the disease probability before the diagnostic test. So it is based on your history and or physical examination of the patient. So it depends on you, no? Kung ano nakita mo sa pasyente, no? So for example, no, para mas madali na intindihan kung ano yung pre-test probability, no? Let's have a case. Sige, ang magbasa naman si Shannon.
23-year-old female with no comorbidities complaining of 2 weeks of pin-pricking pain on the left parasternal border precipitated by certain body position and deep breathing which resolves spontaneously after 1 to 2 minutes. PE, unremarkable except for direct point tenderness on the third rib. Ano to? LPSP.
Left parasternal border.
Left
Okay,
parasternal
sige.
border.
So, kung ang iniisip mo ay, kung ang disease na sa differentials ay ang iniisip mo is isa sa mga differentials, ischemic heart disease, what is the percentage na merong may ischemic heart disease ito given this history and physical examination? So, this is how you do the pretest probability kasi. It is just the percentage na parang probability na merong ganitong disease yung isang pasyente. So, kung ischemic heart disease yung ating disease of interest, no? Ilang percent sure ka kaya na meron siyang, or ilang percent na sa tingin mo na yung patient ay may ischemic heart disease? Yung probability na may ischemic heart disease siya at this point. At this, yan. Given this history and physical exam siya. Sorry, hello? Irinig ba ako? Hello po? Rinig po? Hello? Hello? Nawala ba? Nawala ba si Shannon?
Baka may patient lang.
Ay, sorry.
Kakawag na
Okay,
lang.
sige. Try natin yung mga, mga seniors. Alfred.
Doc, yung competition, Doc,
Walang computation. It's based on your clinical judgment.
pero hindi siya, Doc. Kasi 23-year-old pa lang. Tapos
Oo.
no
So, ilang
comorbid.
percent? 0, 1, 5. What will you give?
Zero,
Anong
zero, Doc.
percent?
Zero.
0. Sige.
Let's go.
Let's go to Maki. Ilang percent yung parang probability kaya na meron tong ischemic heart? Sure na sure si Alfred, 0.
Yes, Doc, less lang din po. 0, 0 din po.
0 talaga. Gemma.
Hello, Doc.
Yeah.
5%.
Siguro bibigyan niya ng 5, no? O, sige. So, let's go now to the second one. Case 2. Si Nathaniel. Or kaya nang choppy siya eh. Okay ka na ba, Nathaniel? Or choppy pa rin
Naririnig po
siya?
ba ako? Choppy pa.
Oo,
Hello?
sige.
Choppy pa din po
Okay
ba?
na, okay na.
Okay. 65-year-old diabetic hypertensive
Okay, choppy siya ulit.
of 1 month history of chest squeezing in character relating to left arm precipitated by exertion and relieved by rest lasting for around 5 minutes. Physical examination is unremarkable except for point of maximum intensity or
Point
on
of
6
max.
intercostal space.
Okay.
Left
Sige.
anterior axillary line.
Okay. So, given that history and physical examination, ano yung percentage na meron siyang ischemic heart disease? Yung kanina, 23-year-old, 0 lahat ang binigay ng mga seniors nyo. How about this case?
Dok, siguro po nasa 80 to 100%.
Oh, so hindi, bigyan mo ko ng number, ng like particular percent. 80, 90?
Mga ganun po, Dok. Mga ganun po. Mga 90 po siguro.
Okay, sige. Okay, si Shannon, ay, ilang percent ka dito na may ischemic heart disease yung pasyente? May pasyente pala siya. Cecilia?
Doc, 95 po.
95. Okay, so pero tingnan nyo yung case 3. Sige, Cecilia, pabasa na lang. Hello?
Doc, narinig po.
Oo.
Ayan po. A 45-year-old hypertensive complaining of 1-month history of substernal chest tightness, occasionally precipitated by heavy exertion and relieved by rest, lasting for 5 to 10 minutes, occurring once a month. PE is unremarkable.
Okay. Sige, if you were the physician, no? Ano kayang percentage or probability for you that this patient ay may ischemic heart disease? In contrast dun sa dalawang earlier case, di ba? Yung una, like 0% halos lahat sila. Yung case 2, 80 to 90%. Case 3, what do you think?
Dok, 50-50 po. So, nasa 50%.
Okay. Nasa 50%. Parang, pwedeng oo, pwedeng hindi. How about the senior, si Doc Bao? O sige, si DM? Duty din ba si DM?
Hindi po, Doc.
Anong probability for you? Percentage siya na meron siyang ischemic heart disease.
Doc,
Given this history.
60% din po, Doc.
50%. So, ganun yung pag-establish ng pretest probability. You just, parang clinical judgment mo lang based on history and physical examination. So, based on the different context, no, di ba? Iba-iba yung ating pretest probability. So, it actually depends on the clinician. So, malinaw kung ano ang pretest probability for the first years. Pretest probability lang pala.
Yes po, Doc.
Okay, so now we'll go to the diagnostic threshold. So ano ba yung diagnostic threshold? This is the disease probability below which we are willing to stop testing and rule out the disease. So for example, if you have a particular disease, let's call it disease X. No, and your diagnostic, ang nilagay mong diagnostic threshold is, usually diagnostic threshold is between 0 to 50%. So if we have yun nga, particular disease na disease X and yung sinet mo na diagnostic threshold is 20% halimbawa. 10% halimbawa. If your patient is 5% lang ang probability na meron pretest probability na meron siya ng disease na yun, essentially i-rule out mo na yung disease. So essentially sabihin mo ay hindi na to yung meron siya at hindi mo na siya itatest for that disease. So, ganun yung diagnostic threshold. Ang tanong, paano ako magsaset ng diagnostic threshold for a particular disease? So, actually, again, it depends on you. And there are factors to consider in establishing the diagnostic threshold. So, these are the factors. So, perceived menace, invasiveness of the test, yung diagnostic test, no, for that disease, the side effects of the test for that particular disease, and the cause of the test. No? So, for example, for the perceived menace, the more dangerous a disease seems, the lower the diagnostic threshold. Ibig sabihin, pag na-miss mo yung disease na iniisip natin, in particular, disease X halimbawa, kapag na-miss mo halimbawa yung disease na to, mamamatay yung patient, ilo-lower mo talaga yung diagnostic threshold kasi ayaw mo siya ma-miss. Okay? So, nasa 10, ganyan. 15%, mababa. Kasi ayaw mong ma-miss yung disease. Pero, kung halimbawa, sa invasiveness of the test, the more invasive a test, the higher the diagnostic threshold. So, kung yung diagnostic test for that particular disease is medyo invasive, like endoscopy, ganyan, biopsy, talaga napapasok pa sa tiyan, mga ganon, medyo dapat higher yung diagnostic threshold mo. Kasi ayaw mo namang ipa-undergo lahat ng mga patient nung invasive na test na parang ang baba naman yung chances na meron siya nung disease na yon. Ganun din for the side effects. Siyempre, the more side effects the test, the higher the diagnostic threshold. And the more expensive a test, the higher the diagnostic threshold. Okay? So, tignan natin to. So, may dalawa tayong disease, no? So, this is, yung first disease is the bronchial asthma na mild intermittent versus cervical cancer. No? Diagnostic test for bronchial asthma is DM.
Doc, spirometry.
Spirometry. For cervical cancer, Nathaniel?
Ano po, Doc? Pap smear po, Doc.
Okay, pap smear. So, let's go first to bronchial asthma. So, iset natin yung mind natin no, na yung disease is bronchial asthma and yung diagnostic test for that is spirometry. So, we begin with the first factor to consider, perceived menace. So, kapag ba na-miss ko yung bronchial asthma, na mild intermittent, mamamatay agad or magkakaroon ng morbidity agad yung pasyente ko? Si Cecilia.
Doc, if the bronchial asthma is mild and intermittent, hindi naman po.
Hindi. So, less dangerous, higher threshold. So, kung 0 to 50% siya, no? Baka pwedeng ilagay ko higher threshold, 30%, di ba? However, no? Invasiveness of the test. Ang test natin is the spirometry. Invasive ba? Si Shannon.
Hindi po, Doc.
Hindi, di ba? So, pwede nating actually, the low invasiveness, lower threshold. So, yung 30 baka pwede nating 25, no? How about side effects? Si Nathaniel.
Doc, yes po, Doc. Side effect po ng spirometry, Doc.
Meron ba siya?
Parang ano naman,
Parang wala naman
po,
halos.
Doc.
Siguro
Wala
mapapagod lang
naman.
siya
Parang,
sa kaka-blow niya doon.
opo.
Although, hindi, guys, ito ay pre-pandemic kasi bawal ang spirometry ngayon because of that, hindi niya masyadong ginagawa. Pero, ayun. So, side effects is, wala naman halos. So, low side effect, lower threshold pa rin. So, 25, pwede pa rin actually nandun or 20%. Cost, magkano ang spirometry? Sino may alam? Sino may alam, guys? How much spirometry cost? Sa mga seniors, baka may alam. Sa mga private. Guys, alam nyo ba? Hello? Hello?
Wala akong idea, Dra.
Doc, sabi ng
Usually-
Google, less than 100,000.
Less than 100, grabe naman.
$100, Doc, sorry.
Ano yung $100 in peso?
Mga 5,000, Doc, mga 4.
Mga ganon, mga 3 to 5,000, no? So, for the cost, kung ang ating mga pasyente ay nandun sa lower na usually naman na medyo nandun sila, medyo high na yun, di ba? So, slightly high cost, so higher threshold. So, pwede namang yung 20 natin, ibalik natin ng 25. So, pwedeng i-set natin actually yung diagnostic threshold natin into 25%. So, kapag ang ibig sabihin nito, kapag yung kapag yung pretest probability ng isang patient nyo na dumating sa inyo, ang pretest based on history and physical examination, yung sa isip nyo, ang kanyang pretest probability is 10%, essentially, hindi nyo na siya i-entertain yung disease na yun, i-rule out yun na, at hindi na kayo magte-test actually for bronchial asthma because your diagnostic threshold for this kind of disease is 20, kung 25% or 20 yung nilagay nyo, ganun yung mangyayari. So, yun yung ibig sabihin ng diagnostic threshold. Gets ba siya so far? Kung naman dumating siya based on history and physical examination, no, ang pretest probability na mayroon siyang bronchial asthma is 30% for you. So, ibig sabihin, kailangan mo pa rin siyang i-test kasi nandun siya sa taas ng diagnostic threshold mo. Gets ba? Or may tanong tayo? Okay, let's have another practice for the cervical cancer. So cervical cancer, no, tas diagnostic test nyo for it is pap smear. So for perceived menace, kapag ba na-miss ko yung cervical cancer, mamamatay, magkakaroon ng morbidity yung pasyente? Si DM.
Doc, yung pap smear po.
Sa pap smear. Even hindi yung pap, when you establish the diagnostic threshold, you think about the disease and the diagnostic test for that disease. So we're talking about cervical cancer, and which we usually screen using pap smear. So, perceived menace, ibig sabihin, if you miss cervical cancer, no, magkakaroon ba ng morbidity or pwedeng mamatay ba yung pasyente mo?
Yes po, Doc. Possible.
Possible. So, it's dangerous. So, the more dangerous a disease is, kapag na-miss mo siya, the lower the threshold. So, kung kanina, no, naglagay tayo 30%, siguro ito dahil nga ayokong makamiss ng cervical cancer. Pag na-miss ko yun, pwede. Tapos matagal yung in-between. Pwedeng kumalat, mga ganon. So, I think I will go for siguro 15%, no, na diagnostic threshold kasi ayokong ma-miss yung cervical cancer. Pero there are other factors to consider. So let's see. Invasiveness. Invasive ba ang pap smear? Si Cecilia.
Doc, pap smear po, hindi po.
Well, medyo konti, pero hindi
Kalahati.
actually. Hindi siya papasok like sa tiyan or sa bibig. No? Pero meron pa rin naman, pero konti lang. So sige, low invasiveness pa rin, lower threshold. So yung 15 natin, pwede nga ibaba pa natin yon. Side effects. Si Shannon. Side effect of pap smear.
Discomfort, doctor. Or
Sa discomfort, syempre, di ba? Discomfort, pwede ding may konting-konting bleeding. Although, kung iisipin mo, hindi naman siya that great. So, low side effects pa rin naman, di ba? So, pwede pa rin actually nando sa lower threshold. And then, for the cost, I think mura lang siya. Meron ba tayong pap smear sa atin? Pero I think it's less than 1,000. Actually, less than 500 for some. Ang cost. No? So, depende kung anong konteksto ng inyong patient. Pwedeng high cost or low cost. Pero yun nga, relatively not yung libo-libo talaga. So, lower cost, lower threshold. So, when, if I'm thinking about cervical cancer in general, no, diagnostic threshold will be like lower. Like 10% or 15% because yun nga, medyo dangerous kasi siya kapag na-miss mo. Unlike dito sa bronchial asthma na medyo kung ma-miss mo man siya, no, hindi naman biglang mild intermittent, biglang mamamatay yung patient o magkakaroon talaga ng morbidity. Gets ba so far yung pag-establish? So actually, walang book ng na magsasabi sa inyo ano yung diagnostic threshold nyo for that particular disease. It depends on you. Siyempre, so ito lang yung guide natin, yung mga perceived menace, invasiveness, side effect cause yung for establishing our own diagnostic threshold for a particular disease. So gets ba, guys? So far? May question?
No questions po.
Sige. So let's go now to the therapeutic threshold. So parang baliktad naman siya. Therapeutic threshold is the disease probability above which we are willing to stop testing and just get on with the disease. So, example ulit, si disease X, ang nilagay mong therapeutic threshold sa kanya is 80%. Tapos may pumasok na pasyente sa clinic mo based on history and physical examination, yung disease probability na may disease X siya is 90. You will just, ang gagawin mo, hindi ka na magte-test further, no? Para i-diagnose yung disease na yun. Parang magko-commit ka na yun yung disease niya at ititreat mo na lang siya. Gets siya yung ganong idea? That's the therapeutic threshold. So ngayon, paano ko isa-set yung therapeutic threshold? So syempre, ulit, depende siya sa inyo. No? It depends on the clinician. And actually, pareho lang din yung factors to consider. However, no, ang factors to consider, syempre, the disease itself, yung danger ng disease kapag hindi tinreat. No, the more dangerous a disease seems, the lower the treatment threshold. So, kung hindi mo siya ginamot, mamamatay yung patient. Hindi mo ginamot, agad mamamatay o agad magkakaroon ng morbidity yung patient, then you lower the treatment threshold. Kasi yun nga, mas gusto mo nang i-treat siya, di ba? Invasiveness, however, kung naman sobrang invasive ng treatment, ano ba yung mga invasive treatment, mga opera, ganyan, syempre dapat medyo sigurado ka na meron siya nun. Kaya medyo, before mo buksan, di ba? Ayaw mo namang ibuksan lahat ng mga pasyente. So, the more invasive the treatment, the higher the treatment threshold. Ayaw mo naman pa-undergo lahat yun sa mga pasyente, no? Side effects, syempre, ganun din siya. The more side effects a treatment has, the higher the treatment threshold. And syempre, the more expensive a treatment, the higher the treatment threshold. So when establishing actually the therapeutic threshold, ang iniisip mo is the disease plus kung ano yung treatment for that disease. In contrast to the diagnostic threshold na, ang iniisip natin is syempre the disease itself and the diagnostic test for that disease. Okay, so let's have a example. Community-acquired pneumonia, low risk, at saka acute appendicitis. So, sige, what's the treatment for CAP? Si Nathaniel, adult CAP, low risk.
Ano po, Doc? Low risk po, amoxicillin po, 1 gram. Azithromycin po, 100 milligrams only for 5 days.
Okay. Pwede rin naman ko amoxiclav, no? Kung may comorbidity siya, low risk, no? O sige. Any of the sinabi niyang antibiotic. So, usually the antibiotic ang binibigay sa CAP, low risk o amox or azit. Okay, so for acute appendicitis naman, syempre, anong gamot dito, Cecilia?
Doc, appendectomy po.
Appendectomy. So we'll go through the first disease muna, CAP, low risk. With yung management lang naman is antibiotic, no? So, perceived menace. So, kapag hindi ko agad tinreat yung CAP low risk, mamamatay si patient or magkakaroon talaga siya ng morbidity. Si Shannon.
Usually hindi naman, Doc.
Usually hindi. So, medyo less dangerous. Pag less dangerous, we could opt to parang ilagay yung therapeutic na threshold natin higher. So, therapeutic threshold usually more than 50% ang mga yan, guys. Sabi dito ha. Siyempre, less than 100. So, sige, dahil medyo less dangerous naman, ilagay ko sa 80% halimbawa o 90%. Sige, dahil less dangerous naman yung ano. And then, invasiveness. Invasive ba ang pag-inom ng gamot? CDM.
Hindi naman.
Hindi. So, pag less invasive, lower ang, pwede mong i-lower yung threshold. So, from 90, pwede naman sigurong 95, no? Side effects. Anong side effect ng antibiotic usually? Si Cecilia. Cecilia? Hello? Hello? Sige. I think. Si Nathaniel.
Ano po, Doc? Possible po, diarrhea, Doc.
Diarrhea, no? Although, yun nga, hindi naman sobrang adverse yung side effect. So, still low side effect, lower threshold. So, yung ating nasa 85, pwede pa rin yung 80 natin, no? Cost. May idea kayo on how much? Pero usually, medyo, sige, depende sa antibiotic siya. So, kung ang binigay mo ay azit, 100 plus to, di ba?
Mga 150 po.
Oh, yeah. O, sige. 150 times 3, di ba? 3 days.
Yes po.
So, nasa 150. 450. So, medyo for our patients, no, kung yung mga taga-ona, medyo yung halimbawa, ano pa yan, badyaw, ganyan, di ba? Medyo slightly higher. So, yung ating from, nasa na tayo? 85. 90, 85, 80. Oh, higher threshold. Pwede para, well, sige, 85% natin siya. So, actually, pwedeng ilagay mo as a treatment threshold is 85%. Pero ito, sa akin lang, ito is by, treatment threshold for CAP. So, ibig sabihin, kung 85% ang nilagay ko, tapos pumasok yung isang pasyente based on history and physical examination, yung probability na may CAP-LR siya ay 90%, hindi na ako magte-test for community-acquired pneumonia. Iti-treat ko na lang siya agad. No? For the disease. Ngayon, kung yung namang, parang essentially, i-commit ko na ito yung sakit niya. Diniagnose ko na siya as that. However, if may yung patient ay pumasok independent and yung based on history and physical exam niya, ang pretest probability niya for me is like 70%. Ibig sabihin, hindi pa ako sure, hindi ako makapag-commit na ito yung sakit niya. So, mag-order pa ako ng diagnostic test before I will commit or rule in or rule out the disease for that patient. So, gets ba siya so far? May question?
Wala po.
Sige, for the appendicitis, let's think about yung sakit na appendicitis and yung management usually is appendectomy. So, perceived menace. So, if hindi ko tinreat ang acute appendicitis, pwede ba magka-morbidity, mortality ang pasyente? Si Cecilia?
Yes po, Doc.
Oo, no? Pwedeng mag-rupture ba yan? Ganyan. So, medyo dangerous. So, lower yung threshold. No? So, ano kaya ang pwede nating ilagay? 80. No? 80%. However, may iba pa tayong factors na i-consider. Invasiveness. Invasive ang appendectomy, right? Kasi bubuksan mo siya. So, high invasiveness, higher threshold. So, pwedeng 85 siguro natin siya. Side effects. May side effect din, syempre, di ba? Opera. So, higher threshold pa rin. And for the cost, no? Syempre, although siguro no balance billing naman, pero I'm not sure kung talagang totally. Pag dyan ba sa ONA, I'm not sure kasi kung may binabayaran ba sila. Hello? Hello? May binabayaran ba? Sorry sa senior, sino rin, may binabayaran ba sila pag appendectomy?
Depende po sa surgeon, Doc.
Usually wala na.
Ha? Usually wala na. Sige, so pwede namang ipalitan to. Pero kung private yan, no? High cost pa rin siya. Kasi medyo may magastos yung opera. No, so higher threshold. So actually for me, no, kung maglalagay ako ng treatment threshold for acute appendicitis, it will be higher, like 90%. No, so ibig sabihin ng 90% na treatment threshold ko for acute appendicitis, if pumasok yung isang pasyente and based on history and physical examination, 95% ako sure na meron siyang acute appendicitis, I will refer na agad to surgeon for appendectomy. No? At hindi na ako mag-order ng labs to diagnose the disease. No, syempre, pero yung iba syempre, may order pa akong labs for another reason. Pero kung for the diagnosis of the disease, hindi na. Kasi actually nandun siya sa after nung treatment threshold ko, which is 90%. However, kung naman may isang patient na dumating, no, and based on history and physical examination, yung aking pretest probability lang na meron siyang acute appendicitis is nasa 80% lang halimbawa, hindi ko pa siya i-commit as meron na acute appendicitis talaga. Mag-o-order pa ako ng lab to diagnose the disease. Gets ba?
Yes po, Doc.
Okay, so as we already discussed the diagnostic threshold and the therapeutic threshold, so we now go to the testing range. It is simply yung range in between your diagnostic threshold for that particular disease and your therapeutic threshold. So, ayan, probability of disease between the diagnostic and therapeutic thresholds. And this is the time na unsure yung clinician kung talagang yun yung disease yung, na meron yung patient. Like yun sa case 3 natin kanina. 50-50, nasa hindi ako talaga sure. So, the further tests are required to establish the diagnosis. So, yun lang. Yun yung testing range. And then, when the pretest probability falls outside the testing range, there is no need, sabi ko nga, di ba, for further testing or laboratory examination to establish diagnosis. Kasi nga, kung yung pretest probability mo ay nandito sa baba ng diagnostic threshold mo, ibig sabihin, essentially sa isip mo, ni-roll out mo na yung disease. Or kung yung pretest probability naman niya ay lumagpas sa therapeutic threshold mo, in essence, sa iyo, yun na yung disease niya at ititit mo na lang. Sure ka na yun yun. Pero yun nga, testing range, ito yung in-between, di ka talaga sure. Kaya magpapatest ka to establish the diagnosis. So, when the pretest probability falls inside the testing, ayan, sinabi ko na yun. So, malinaw ba so far? Diagnostic threshold, therapeutic threshold, and testing range. Sa mga seniors, guys, okay lang. Malinaw ba? Maki? Gemma?
Yes po, Doc.
Okay, so let's have an example. We have disease X, no? Tapos ako as a clinician, ang nilagay kong diagnostic threshold ko for that disease is 15%. No, hindi the diagnostic test for it. And then yung sinet ko for that disease na therapeutic threshold is 80%, no? Anong gagawin ko if the pretest probability yon, may pumasok na pasyente, ha? And the pretest probability na meron siya nung disease X is, hello? Hello? Ayan. So, halimbawa may pasyente na pumasok and based on history and physical examination, yung pretest probability ko sa kanya na meron siyang disease X is 10%.
Wala siyang patient.
What will be the management for this patient? Si Nathaniel.
Ay, capsule na pala siya.
Yes po, Doc.
Ito. Given yung itong given sa screen. The pretest probability is 10%. What will be your management, Nathaniel? Hello?
Ano po, Doc? Treat po, Doc.
Why? Sige, try natin si Maki. Maki? Hello? Rinig po ba? Gemma? Hello? Hello po? Sige. Si Shannon. Shannon?
Hello, Doc. Sorry, may patient lang.
Sige, si DM.
Sorry.
Doc, not sure po pero na-diagnose po na po natin, Doc. Using laboratory.
Anong gagawin?
Papalabs muna, Doc.
Papalabs. Bakit? Nagpapalabs tayo, di ba, kapag nasa testing range. Ang pretest probability mo is nasa 10%. This is 0, this is 100. Your diagnostic threshold is 15%. Ito yung sinet mo, halimbawa. And your therapeutic threshold is 80%. What if the patient na may comes to you with the pretest probability na disease X is only 10%? Actually, dahil nga siya ay nandito sa below your diagnostic threshold, essentially, i-rule out mo na yung disease for that patient and you will no longer order the laboratory test for that disease kasi essentially, ni-rule out mo siya for that patient. Kapag less than 15% yung iyong diagnostic threshold for that disease. Okay? And then, what if the pretest probability is 85%? Cecilia?
Doc, more, diagnostic.
Actually, no, because you set your therapeutic threshold at 80%, yun nga, ang ibig sabihin, if it falls after your therapeutic threshold, essentially, i-commit mo na meron siya, no, ang disease na yun, and you will just treat the patient. You will no longer order diagnostic for that disease kasi kinumit mo na siya yun. at i-treat mo na lang yung patient na yan for that disease. What if your pretest probability is 50%? Si DN.
Dok, pag 50% po, siguro po magre-request pa ako ng ibang diagnostic test to increase po yung ano natin.
Okay. Bakit? Kasi it falls within your testing range.
Yes.
So any pretest probability na falls between 50 to 80%, hindi ka pa nga makakapag-commit ng iyong diagnosis. So you will order a diagnostic examination to establish the diagnosis. Yun nga. So sana malinaw, no? Na when your diagnostic threshold, nag-set ka ng diagnostic threshold and then below which kapag ganun yung iyong pretest probability, niro-rule out mo na yon yung disease for that patient. So for this example nga, kung halimbawa 15% yung diagnostic threshold na sinet mo and pumasok yung patient, ang pretest probability na meron siyang disease X is only 10%, essentially you will rule out that this is for the patient. Di mo na siya i-entertain. Hindi ka na mag-order ng diagnostic examination for that disease X kasi parang sa'yo, essentially ruled out na. Hindi yun yung kanyang sakit. And for the therapeutic threshold, kung nagpo-fall siya after the therapeutic threshold, di ka na mag-order ng labs to establish that diagnosis and just treat the patient. So for this case nga, di ba, 80% kung ito yung nilagay na therapeutic threshold at ang pumasok na patient sa'yo, based on history and physical examination, ang iyong pretest probability is 85%, hindi ka na mag-order ng labs and you will just you will just treat the patient. Parang yun na yung, for you, yun na yung disease niya. Okay, so malinaw ba? Kasi before we go on to the critical appraisal, medyo dapat malinaw siya, itong decision analysis line, because you will actually use it in the end. Pag nag-a-apply ka na ng, i-apply mo na yung results ng journal dun sa patient mo. So, kung may question dito or kung hindi pa siya masyadong malinaw, we could go back, no, to discuss it further. So, may question ba?
Excuse po.
Mhm.
Opo. Okay lang po bang makita po yung slide before po nito? Medyo nalito lang po kasi ako kanina. Sorry
Okay.
po.
Okay lang. Medyo mahirap siya pag first. Ayan. Ito ba?
Po, Doc. Okay po, Doc.
So
Okay po, Doc.
actually,
Thank you po.
yung mahirap sa akin actually minsan is yung pag ano lang talaga, pag-establish ng for me, ano yung diagnostic threshold ko for this disease, and ano yung therapeutic threshold ko for this disease. So, siguro yun yung medyo i-practice lang. Pero remember, diagnostic threshold usually nandyan yan sa baba ng 50% and yung therapeutic threshold, syempre kasi ito yung i-rule out mo na yung disease, diba? And therapeutic threshold is usually yung more than 50% kasi ito yung part na i-treat mo na yung i-commit mo na siya as yun yung sakit niya. Okay? Sige. May question pa? Guys, itanong nyo lang para at the end, no, magamit natin ng maayos yung decision analysis line. Okay. So, sa seniors, okay lang? Malinaw ba? Sige. Sino ba yung mga seniors? Doreen? Hindi ko masyadong nakikita kasi. Okay, malinaw ba or we need to discuss it further?
Okay na po.
Sige. So, sa first years, may additional question. Probably, ibibigay ko naman yung slides. So, we just siguro need to review it on your own. Minsan, kailangan lang ng practice, no? So to grasp yung concept ng decision analysis line, diagnostic threshold, therapeutic threshold. Okay, so let's go now to the actual critical appraisal. Pero actually, I could cut it here kung para sa susunod na lang yung subsequent na mga slides. Hello, sir.
Yes, Abby, siguro.
Baka medyo, oo, baka medyo, sila, tsaka, ayan. So, I could just give the copy of yung, sorry po, of the first few slides, no, para ma-review, para dun sa next na, next na meeting, mas, pwede nyong itanong kung may clarifications kayo regarding that before we go on to the critical appraisal. Okay lang po ba yun? Ganun na lang. Kasi minsan kapag biglaan siyang diniscuss, medyo malabo pa talaga pag una. So kapag nabasa ulit, ayun, doon nagiging mas malinaw siya. So ibigay ko na lang, Doc Tyrell po, yung first few slides nung and then they'll just review it. Tapos kung may question po sila, they could ask it on the subsequent lectures.
Okay, Abby, thank you.
Thank you po sa lahat.
Kung may time next
Abby.
Thank you po, Doc.
Thank you,
So,
Doc.
siguro review ulit para next time mas malinaw siya.
Medyo mahirap talaga siya nung first time din na narinig ko siya. Magulo yung diagnostic at therapeutic threshold. Pero yun, basa-basahin
Lalo na kasi
lang.
ikaw yung magsiset kasi, di ba?
It's your prerogative actually. So, medyo mahirap siya.
Malalaman mo baka masyado palang mababa or masyado mataas yung sinet mo. Di ba ganun siya?
Yes po. Yes, sir. So, clinical judgment talaga siya. So, what we can do is just guide you on how to set your own parang diagnostic and therapeutic thresholds for certain diseases. Parang gano'n. Ayun. So, okay, mag-alala guys, talagang siya. Mahirap siyang i-grasp. Mahirap siyang, nakakalito pa siya. So, pakiread na lang, no, yung first 3 slides and we'll discuss it further kung medyo mas, malabo pa rin siya sa susunod. Yan lang.
Okay, thank you, Abby. Okay. Siguro let's call it a night. Try natin next week kung may time si Doktora.
Okay naman po, sir.
Okay.
Wala naman pong problema kung kung next Monday? Next Monday
Yes,
po
next
ba?
Monday.
Opo. Sige po, sir.
Okay, salamat. Okay.
Thank you po.
Wala naman akong sasabihin din. With regards pala dun sa DTR, no? Please, submit na po yung DTR natin para ma-process na po yung pagsweldo. I believe wala pang nakapagpirma, no? Pero I asked Doc Froy kanina, hindi ko maintindihan yung explanation niya eh. Pero sabi naman ni Ma'am Fat, pinapaprocess na yung yun nga, hinihingi na yung DTRs for July and August para ma-process na yung payroll. So I guess baka mauna yung sweldo kaysa doon sa contract. So there. Thank you. Reminder lang, no, alam ko toxic talaga lately. Madaming pasyente, so medyo napapasabak tayo sa duty. Reminder lang to be more patient, no? Yung pakikitungo natin sa pasyente, saka sa mga kasamahan natin sa ospital, haba-habaan pa yung pasensya. Yun lang.
Doc, tsaka pwedeng remind din po yung yung mga pasyente sa tent, minsan hindi na rounds.
Ayun na nga, no? So, dapat kahit pa paano we make time for them. And yung mga patient nyo na halimbawa 2 days, 3 days na sa tent, tapos COVID confirmed or even yung highly probable na COVID, if you think, di ba dati ang remdesivir, si Doc Kit ang nag-decide, no? Siya na yung nag-order. Pero if you think sa tent pa lang kailangan na niya ng remdesivir, by all means, i-refer nyo kay Doc Kit. Magbibigay naman niya ng go signal para at least ma-start. Although, alam natin ngayon na wala naman ding remdesivir, pero at least for those people who can afford it, willing bumili sa labas para makagawa sila ng paraan. With regards to the other medications, I believe may mga antibiotics na nag-run out na rin ng pharmacy, di ba? Mga IV antibiotics. Sabi kanina, ano na ng purchase order. So hopefully within the week, magkaroon na ulit ng mga gamot. Alright, yun lang. Any other, Doc? Joser? O kung wala na, thank you. Good night, everyone.
Night, Doc.
Night, Doc.
Thank you po.
Ay,